Welcome to AETCM, the emergency medicine channel. Today let us discuss about jaundice and its importance in clinical practice. We know that jaundice means it is the elevation of bilirubin in our body. Bilirubin is produced by heme catabolism. That means when the RBCs are becoming old, they will be self-destructed in our circulatory system. That is only after 120 days of normal lifespan of RBC, it will be destroyed in our circulatory system. During that period, bilirubin will be formed, then that is bound with albumin, that is unconjugated bilirubin. When the bilirubin enters to the liver, there it is conjugated with glucuronic acid by an enzyme, that is gluconyl transferase. This is called as conjugated bilirubin. That time albumin will be removed from the bilirubin, and once it is released from the liver through bile, it will enter to the duodenum. Then most unconjugated bilirubin is excreted in the stool, but some reabsorbed and returned to the liver for reconjugation. So that is called as intrahepatic circulation. The bilirubin which is coming to the stool through the intestine will give yellow color to the stool. So all these things are very important, because when we are managing a case of jaundice, if we know all these things, it will be very easy to identify where is the lesion. So bilirubin which is formed from the RBC lysis is bound with albumin, that will not be going through the kidneys. So even if the unconjugated bilirubin levels are elevated, urine color will be normal. But whereas once it is conjugated, it is removed, the albumin part is removed, and the conjugated bilirubin can go through the kidneys, and that can give yellow color to urine. Again, if the bilirubin circulation is blocked after the liver, that is post-hepatic obstruction, the bilirubin will not go to the intestine, and the yellow color of the stool will not be seen. That the stool will become clay colored. So that is obstructive jaundice. We will see all these things afterwards. Now you can see the RBC breakdown into during hemolysis. Sometimes due to some increased hemolysis, the levels can be exaggerated. This unconjugated bilirubin is bound with albumin, so it will not be going through the kidneys. So urine color will be normal in unconjugated hyperbilirubinemia due to various reasons. Once it is entering to the liver, it is called as conjugation. It is done by an enzyme, that is gluconyl transferase. So it will be conjugated with gluconic acid, and albumin will be removed. This conjugated bilirubin can go through kidneys, and it can produce yellow color of urine. So any cause for conjugated hyperbilirubinemia, urine color will be yellow. Now once it is entering to the intestine, that gives yellow color to stools. If that part is obstructed, that means obstructive jaundice, the stool color will be clay color, because the color of the stool normally is produced by the yellow bilirubin. Now on examination, what you can see here, this patient's hands are yellow, eyes are yellow. So both eyes and hands you can pick up yellowish discoloration due to jaundice. Clinical jaundice occurs when the serum bilirubin more than 3 mg per deciliter. Latent jaundice means serum bilirubin 1 to 3, but patient is having some prehepatic or hepatic, post-hepatic lesions. The problem with jaundice is jaundice can persist even after the clinical problem subsides. The patient can still have clinical jaundice. That means the accumulated bilirubin in the sclera can remain there for longer period. So a patient who had viral hepatitis 1 or 2 months back still can have yellow sclera, but his all lab parameters including bilirubin may be normal. So it will be very difficult. Sometimes you can see patient who is having jaundice, LFT will be completely normal, bilirubin will be completely normal. So all these things can occur in clinical practice. Now if you classify jaundice, there are two important classifications that we already seen: unconjugated hyperbilirubinemia. It is predominantly due to increased production of bilirubin by hemolysis, decreased hepatic uptake or decreased conjugation. These are the liver enzyme problems. Glucuronide transferase, we have seen that enzyme problem can this type of diseases. Conjugated hyperbilirubinemia can be mainly due to hepatocellular dysfunction. It can be due to cirrhosis, hepatitis, so many other alcoholism, so many conditions. And post-hepatic, that is obstructive type of jaundice, both can have conjugated hyperbilirubinemia. Now, hemolytic conditions, hemolytic diseases can produce jaundice. That means patient can have mild jaundice, patient can have anemia. Remember, here patient can have mild jaundice because patient is having mild to moderate hemolysis that produces mild jaundice, that will be lemon yellow in color. Urine color will be normal. There will not be any dark urine or there will not be any yellow urine because the bilirubin, unconjugated bilirubin bound with albumin, will not be passed through the kidneys. Stool color will be like natural yellow color. So this will be the clinical finding of hemolytic jaundice. When we are talking about hemolytic jaundice, there are different types of hemolytic jaundice. It can be intraerythrocytic hemolysis, that means problem inside RBCs, or extra erythrocytic hemolysis, problem outside the RBC. Inside RBCs, it can be membrane defects, hemoglobinopathies, enzyme defects, or acquired defects like B12 deficiency, folic acid deficiency, PNH. All these conditions can produce problem inside RBC and it can lyse the RBC. Whereas extra erythrocytic means again malaria, toxoplasma, mycoplasma, large spleen destructs large amount of RBCs, trauma, burns, disseminated intravascular coagulation, graft rejection, many chemicals, snake bite, autoimmune diseases like autoimmune hemolytic anemia, many malignancies including lymphoma, transfusion reactions, hemolytic disease of newborn, and other conditions also can, many other conditions also can produce hemolysis. Whatever it is, when there is increased amount of hemolysis, up to some extent, liver can manage the bilirubin elevation in the bilirubin. It can metabolize the bilirubin, but after that, if the hemolysis is severe, you can see the indirect hyperbilirubinemia can be there in the blood testing. Indirect hyperbilirubinemia, that means direct will be normal, indirect bilirubin will be elevated. Normally, you can see the bilirubin level may be 1.2 to 1.8, but here it will be very high. Indirect bilirubin may be 3 or 4. It will be never more than 6 in most of the clinical conditions unless it is a severe hemolysis. Most of the hemolytic condition, it may be 3 to 6. That is indirect. Now, there are some conditions called as congenital non-haemolytic unconjugated bilirubinemia. Here the problem is with the enzymes. The conditions are Crigler-Najjar syndrome, Gilbert syndrome, Dubin-Johnson syndrome, Rotter syndrome. Here all the problem is with the enzymes that we have seen. The glucuronide transferase is the enzyme which is producing the conjugation of the bilirubin. Here the problem is with the glucuronide transferase enzyme. In that, one important condition is Gilbert syndrome. It is not a disease. Gilbert syndrome is a benign condition. Here you can see bilirubin levels are elevated, that is indirect hyperbilirubinemia can be there, and during prolonged fasting you can see that again the bilirubin may be little bit more elevated, but that doesn't mean that patient is having any clinical disease. One of the most commonly seen jaundice is Gilbert syndrome. Any patient you see without any reason, if the bilirubin is slightly elevated, that is indirect hyperbilirubinemia is elevated, that is mostly Gilbert syndrome. That type of patients does not require any treatment because they don't have a problem with the liver, they don't have a problem with hemolysis, they have minimal problem with glucuronide transferase enzyme, but that will be taken care by your liver. So nothing to do all these conditions, especially Gilbert syndrome. Other conditions, there will be difficulty in early childhood. Patient can have a lot of difficulties, including that kernicterus, like that problems that we are not discussing here. Now again, based on lab investigation, we can again classify jaundice into unconjugated or indirect hyperbilirubinemia or direct hyperbilirubinemia. All conditions including hemolysis and glucuronidyltransferase enzyme defects are coming under unconjugated or indirect hyperbilirubinemia. All conditions which includes liver disease, cirrhosis, post liver obstruction, malignancies, all those things comes under direct hyperbilirubinemia. The main difference between indirect and direct is elevated bilirubin, which is mostly due to hemolysis here, or a mild defect in the liver enzyme, that is glucuronidyltransferase. Here the liver is absolutely normal, whereas a conjugated hyperbilirubinemia, most of the time liver is a culprit and liver problems are there. So patient can have liver disease or sometimes obstructive jaundice. That means after liver, the canaliculae or the main bile ducts are blocked. So that is conjugated hyperbilirubinemia. Now we have seen it is divided into three major classes that we have seen. Different types of classification we have seen previous slides, but ultimately it is classified according to the pathology, that is hemolytic jaundice, hepatocellular jaundice, cholestatic jaundice. So all these things are major problems. Hemolytic jaundice means increased amount of hemolysis that elevates the indirect hyperbilirubinemia. Hepatocellular means liver disease that elevates direct hyperbilirubinemia. Third one is cholestatic jaundice, that means post liver, that is bile duct obstruction can be there, that produces cholestatic jaundice. Now we can see the differentiating features here: hemolytic jaundice, mild jaundice, hepatocellular jaundice, orange yellow, obstructive jaundice, severe yellow or greenish yellow. Itching is classically seen in obstructive jaundice. Bleeding tendency is mainly seen in obstructive jaundice and also seen in hepatocellular jaundice, not seen in hemolytic jaundice. Bleeding tendency is due to elevated prothrombin time and INR, that's a function of liver, so it is elevated here. In obstructive jaundice, it is due to the reduced absorption of vitamin K, that's a fat soluble vitamin. Bradycardia is classically seen in obstructive jaundice. Anemia can be seen in all types of jaundice, but mechanisms are different. Hemolytic jaundice, it is due to hemolysis. Hepatocellular jaundice, it is due to bleeding. Obstructive jaundice, it is mostly malignancy induced, low production of RBCs. Splenomegaly can be seen in almost all types. Hemolytic jaundice, it's a part of hemolysis. Hepatocellular jaundice, it is due to portal hypertension. Obstructive jaundice, it may be due to the infiltration of malignancy to the spleen. Palpable gallbladder is mainly seen in obstructive jaundice. Very rarely it can be seen in hepatocellular jaundice. And hemolytic jaundice, you can get gallbladder stones, but you will not get a palpable gallbladder. That is the main difference. Gallbladder stones are very common in hemolytic jaundice, whereas obstructive jaundice, the cause of obstruction itself may be a gallbladder pathology or pancreatic pathology. Other differentiating features are very, very important, because when we are trying to investigate a jaundice case, we should know about this investigation. Bilirubin, hemolytic jaundice, it is indirect hyperbilirubinemia, whereas hepatocellular post-obstructive jaundice, it is direct hyperbilirubinemia. SGOT, SGPT is classically elevated in hepatocellular jaundice, mildly elevated in obstructive jaundice, and sometimes it may not be elevated, whereas hemolytic jaundice, it is normal. Prothrombin time and INR, we have already discussed that it is due to the liver functional inability, the PT-INR can be elevated, whereas in obstructive jaundice, vitamin K deficiency can produce elevated PT-INR. Albumin globulin reversal is classically seen in hepatocellular jaundice because albumin production is reduced in chronic liver disease. Urobilinogen is increased in hemolytic jaundice. but urine bilirubin is not seen in hemolytic jaundice. LDH is classically elevated in hemolytic jaundice. That is very important. Any hemolysis, LDH will be elevated. Alkaline phosphatase is classically elevated in obstructive jaundice, but in obstructive phase of hepatocellular jaundice also it may be slightly elevated. Obstructive phase of hepatic jaundice means whenever there is an acute inflammation of liver cells, the inflamed liver cells can obstruct the canaliculae inside the liver, so that can produce sometimes elevation in the alkaline phosphatase. So any acute hepatitis can have some mild elevation in alkaline phosphatase, whereas in obstructive jaundice it will be severely elevated, it will be highly elevated. Causes we already discussed, that we are not going to discuss that causes again and again. Now other conditions also we should remember. Gilbert syndrome, bilirubin will be elevated, indirect hyperbilirubinemia can be there, rest all can be normal, patient will be asymptomatic. After prolonged fasting, you can see again bilirubin levels are a little more elevated, but there is no treatment required for Gilbert syndrome. Acute hepatitis, you can see bilirubin is elevated, both direct and indirect is elevated, direct is more than indirect, and SGOT, SGPT will be in thousands. Chronic liver disease, bilirubin will be elevated, direct will be elevated, SGOT, SGPT will be mildly elevated, not like acute hepatitis, and albumin globulin reversal is seen in chronic liver disease. In obstructive jaundice, you can see that bilirubin is elevated, direct is highly elevated, there will not be any significant elevation in SGOT, SGPT, AG reversal, nothing will be there, but whereas alkaline phosphatase will be highly elevated. Any infiltrative disease also you can see alkaline phosphatase will be highly elevated. So we have discussed about one of the important clinical condition, that is jaundice. You can see different types of jaundice, whatever it is, ultimately it is divided into hemolytic and hemolytic jaundice, hepatic jaundice and post-hepatic jaundice. Basic investigations, we do a routine CBC, we do bilirubin levels, we do liver function test, and we do an ultrasound if it is a direct hyperbilirubinemia to see what is the structure of liver, what is the echotexture of liver, any obstructive features are there, any splenomegaly is there. So these are the basic investigations, and depending on the basic investigation, like hemolytic anemia means hemolytic jaundice means, then we have to do investigations for that. We can see for membrane stability, we can do fragility test, hemoglobin, electrophoresis, peripheral smear, sickling test. So many tests are there for hemolysis. Liver disease, we can do liver function test, albumin globulin ratio, PT-INR, APTT, ultrasound, CT scan abdomen, all these things can be there. And again, post-hepatic jaundice, you can see whether any obstructive lesions are there. We can ask for a CT scan and see where that is present or not. One more important thing is, on clinical examination, what you see in patients are, patient will have severe itching in obstructive jaundice, and one more thing is stool color will be clay colored in obstructive jaundice, whereas stool color will be normal in other types of jaundice. Urine color will be normal in prehepatic jaundice, that is hemolytic jaundice, but whereas urine color will be highly yellowish in hepatic and post-hepatic jaundice. Thank you.